Hello and welcome back everyone. So continuing our discussion about the airway management, and after we talked about the bedside assessment of the airway and the airway management modalities, now we are going to talk about the mask ventilation. So mask ventilation is indicated in patients with respiratory arrest, means apnea, and in patients with impending respiratory arrest, which are gasping patients. Now, it is also indicated prior to intubation to provide 100% oxygen to the patient to allow for enough time to insert the tube without running into hypoxemia. And mask ventilation can be achieved with one provider using the bag valve mask. So one of the provider hands will be pressing the bag and the other hand will be holding the face mask, making a seal with the face. Mask ventilation can also be achieved with two providers using the bag valve mask also. One provider is dedicated to holding the face mask and maintaining a tight seal with the face, and the other provider is responsible for pressing the bag to provide just enough volume to raise the chest. And mask ventilation can also be achieved with one provider and mechanical ventilator. The one provider is responsible for holding the face mask and maintaining a seal with the face, and the mechanical ventilator is responsible for pushing the air. Now, an essential tool used in the mask ventilation is the bag valve mask, and you can see it in this picture here. So it contains a self-inflating bag, which is this here, which is attached to a non-rebreathing valve, you can see here, and it is also attached to a face mask here, and from the other side it is attached to a reservoir bag and an oxygen source. Now, to start mask ventilation, there is steps you have to follow. So starting from step 1, the patients should be placed in a sniffing or ramped position. Sniffing position means head tilt and chin lift and or jaw thrust. So as you can see in this picture here, the head will be tilted like that and the chin will be lifted this way. And jaw thrust also can be done by lifting the jaw upward. This method will lift the soft tissues such as the tongue upward and open the airway to allow the air to go through. Now, in trauma patients suspected for C-spine injury, only jaw thrust is done. You can't do the head tilt chin lift because it will lead to spinal cord injury. Now, step 2, the airway adjuncts should be placed, such as the nasopharyngeal airway and the oropharyngeal airway if the patient doesn't have gag reflex. So nasopharyngeal airway is inserted most of the time, except in patients with severe facial trauma and patients with basal skull fractures, for reasons explained in the previous video of this series. And also, the oropharyngeal airway must be placed if the patient doesn't have gag reflex. And if possible, 2 nasopharyngeal airways should be placed and 1 oropharyngeal airway should be placed at the same time. Now, step 3 is applying a properly fitted mask, and the mask should cover the mouth and the nostrils without any gaps between the mask and the face. And there is an adult and pediatric masks, so there's different sizes. If the patient is adult, you have to choose the bigger masks, and if the patient is pediatric, you have to choose the smaller masks. Now, in step 4, you make a good seal between the mask and the face, and there's many grips that you can use to grip the mask. One of these is the CE grip, which is called the anesthetist grip, and this grip is explained in this picture here. So you hold the mask with the thumb and the index like that, and you lift the jaw of the patient with the other 3 fingers here. So it's a CE grip because your thumb and index make the letter C, and then your other 3 fingers make the letter E, like that. Now, the CE grip can be done with 1 hand or 2 hands according to how many emergency providers you have. So if it is done by 1 hand and gripped from the side, then the mask will tilt to one side, allowing the air to leak under the opposite side, such as you can see in this picture here. So the mask is held with a CE grip from this side, and the mask will tilt from this side upward, allowing the air to escape this way. And if the mask is gripped around the lower half of the face, like you can see in this picture here, then it allows the air to escape through the nasal bridge. So if it is gripped from the lower half, then you get the air escaping upward. And if the mask is gripped with a rotated grip, which is called the rotated hold, like you can see in this picture here, then it provides a better seal than both of the techniques mentioned already. So the rotated grip, like you can see in this picture, provides a better seal if only one hand is responsible for controlling the mask. Now, if two providers are involved, then the mask ventilation will be more effective. One provider, which is the operator, can concentrate on their bag valve mask technique, while the second provider, which is called the assistant, can use both hands to provide an effective mask seal on the patient face. And if two hands are involved in controlling the mask, then you have two grips that can be used. So you have the CE grip and you have the thinner eminency grip, which is called the TE grip. T is from thinner and E from eminence. So the CE grip you can see in this picture here. So both hands are controlling the mask and they both using the CE grip, and the thinner eminency grip you can see here. So it is achieved by using the thinner muscles to place downward pressure on the mask, while the four fingers of each hand pulling the jaw upward. So the thinner eminence of both hands is controlling the mask, while the other four fingers are lifting the jaw. And the thinner eminency grip is more effective in making a good seal with the face than the CE grip, because it allows for lifting the jaw more than the CE grip. Now, if you are unable to achieve a mask seal, consider placing an extraglottic device if there is no gag reflex or other contraindications to the extraglottic device, or if there is contraindications, then endotracheal intubation is needed. Now let's move on to step 5, which is volume, rate, and pressure of the ventilations given to the patient. So let's start with the volume. So previously, the volume per ventilation for adults was 800 milliliters, but recent guidelines suggest a more conservative 6 to 8 milliliters per kilogram per ventilation. And this is the same as the normal tidal volume, which is for an adult weighing 80 kilograms, it is approximately 480 to 640 milliliters per ventilation. And this number is even less for patients with non-respiratory illness. Now, higher volumes than 8 milliliters per kilogram would risk gastric insufflation, so air going to the stomach and pushing the stomach contents backward and leading to aspiration of these secretions. And it also leads to hypocapnia and barotrauma to the lungs. Now, in reality, these metrics are not that useful because they will vary with each patient weight and lung capacity, and you don't have much time to calculate the volume of air you have to give. So it is best to look for adequate chest rise and fall with each ventilation. Regarding the rate of the ventilations given, so for patients in cardiac arrest, current United Kingdom and European guidelines recommend inflation during 1 second every 5 seconds, resulting in a rate of 1 complete ventilation every 6 seconds, or 10 ventilations in a minute. Now, that is for the patients in cardiac arrest. Now, if the patient is breathing spontaneously, then the normal resting minute ventilation in humans is around 70 to 100 milliliters per kilogram every minute, and it is achieved by delivering the normal tidal volume, which is 6 to 8 milliliters per kilogram per ventilation in a rate of 12 to 16 breaths per minute, which is the same as the normal respiratory rate. So if the patient is not in cardiac arrest, then you give them air the same as their normal respiratory rate. Regarding the pressure of each ventilation, so in bag valve mask ventilation, it is possible to overinflate the patient by squeezing the bag too hard or too fast or too much. Now in respiratory pressures, if exceeds 20 milliliters mercury, this would increase the risk of forcing the air into the stomach, which is gastric insufflation and aspiration. So in respiratory pressures should be around 15 millimeters mercury. Now the bag valve masks that are equipped with the pressure responsive and flow limiting valves reduces the mean airway pressure given, thus reducing the risk for the gastric insufflation compared to standard bags. Now let's talk about the PEEP, which is the positive and expiratory pressure, and the PEEP may be used during bag valve mask ventilation to improve oxygenation, and the PEEP keeps more alveoli open and prevents atelectasis, thus improving oxygenation, and it also prevents lung injury. Now the idea behind the positive and expiratory pressure is that when the patient expirates, there is still some pressure given to the patient, preventing the alveoli from collapsing. Because there is always pressure present, the alveoli can't collapse, so they will be always open. And this is useful in patients with respiratory diseases. Now the PEEP should be used cautiously in hypotensive or heart failure patients because it would aggravate the hypotension and it would decrease the preload in patients with heart failure. Now let's talk about the difficult bag valve mask ventilation. This is very important to remember because once you see these signs, you will have an idea that the patient would need an extraglottic device or endotracheal intubation very fast because the bag valve mask ventilation will be not as effective for these patients. And the characteristics of the difficult bag valve mask are collected in the mnemonic of Mounds. So the M for mask seal, and that is in patients with facial hair or facial trauma, the mask seal cannot be achieved to a good degree because the hair or the trauma can interfere in achieving adequate seal. The O stands for obesity obstruction. Obesity means there is increased soft tissue in the airway and it may cause further occlusion when the patient in altered mental status. The A in Mounds is for age, so extremities of age can be difficult to ventilate due to anatomic changes, and the N is for no teeth, so the bag valve mask ventilation in no teeth patient is ineffective, and the S in Mounds is for snoring because snoring means that the soft tissues such as the tongue is occluding the airway and the airway maneuvers and adjuncts are required. So in difficult bag valve mask ventilation, a supraglottic airway or intubation is preferred. Finally, let's talk about the complications. So mask ventilation may accelerate hypoxia if not enough oxygen is delivered, and it may accelerate hypercapnia if not enough carbon dioxide is removed, leading to brain damage. And mask ventilation may also lead to overventilation, which can exacerbate existing lung injuries and lead to gastric insufflation and subsequently aspiration. And with that, we reach the end of this video. Thank you guys for watching. Please give us a like, comment your ideas and questions, and subscribe. And you can support us more by joining the channel. The join button will be near the subscribe button down, or you can join through the link in the description of this video.